Thank you, Joseph, for such provocative questions and also sharing your opinion about who knows what and who knows nothing. And I would like to continue now with Marina Karanikolos, and she will highlight more about our financial crisis and how financial crisis could affect and how we can have certain issues to be solved before or during financial crisis that health couldn't suffer.
Good afternoon. My name is Marina Karanikolos, and I work for the European Observatory on Health Systems and Policies. And also, I'm based at the London School of Hygiene and Tropical Medicine. And today, well, I'm going to talk about given that health is human capital, how this human capital was affected during the financial crisis and economic crisis in Europe. But before I begin, I would like to thank my colleagues that I've been working with on this study that we've done on the financial crisis, and that's Professor Martin McKee, Dr. David Stuckler, and the observatory team from the London School of Economics, and also Dr. Aaron Reeves, who's sitting here in the audience, because I will be heavily relying on their work today. So the crisis has started about 5 years ago and has led European countries to be on a different track from the economics perspective. And what we see on this graph is that countries like Germany and the United States today are slightly better off than they were before the crisis, and these are the countries that implemented stimulus packages, whereas some other countries in the Eurozone and some other European countries are trailing a little bit behind, and my apologies, Lithuania is not here because this is OECD data, but Estonia is there right at the bottom with quite a big slump during the crisis and coming up, but still all these countries, they haven't quite reached their pre-crisis level yet. And that also had an impact on the employment in these countries, and particularly worrying our data from Greece and Spain, and now they've reached 26% of unemployment and more than 55% of unemployment among the young people. And of course, this has an impact on the health systems, and this is something that Susanna Jakob mentioned earlier today. But I would like to talk today more about the impact on health. But what we know from the body of evidence that exists today sort of looks like there are two kinds of theories. One says that recessions are good for health, and that when economy speeds up, mortality grows. And this is mainly work by Chris Room and Tapia Granados, and they've looked at high-income countries, and most of their data looks at up to mid or end 1990s. But there is another theory that recession is bad for health because unemployment or loss of income might not affect people very well. And the evidence for that comes mainly from individual level studies, also for high-income countries and Scandinavian countries and the United States, Canada, and across European Union. And this is one of the examples. This is work done by David Stuckler and colleagues. He looked at almost 40 years of data starting from 1970s for the European countries. And what he found was that 1% rise in unemployment led to increase in suicides, increase in homicides, and decrease in road traffic accidents. And more than 3% rapid rise in unemployment led to increase in alcohol-related deaths. And the overall mortality rate remained unchanged or unrelated to changes in the economy. But this is overall for Europe. While looking at separate countries, the picture is quite different, and these are examples from Spain and Sweden, whereas in Spain, the unemployment, which is the red line, and suicides go together, while Sweden managed to decouple the relation between unemployment and suicide during the crisis. So what's happening in Sweden is that it spends about 4 times more on active labor market programs, so it returns people to work much quicker, and it gives them training and so on, and all kinds of social support to get them back quicker into work. So it's not just the health spending that we were talking about earlier today, it's also the social spending that can improve population health or protect population health and mitigate the impact of the crisis. So this is another study by the same group of colleagues who found that $100 per person per year increase in social welfare spending was associated with a significant drop in all-cause mortality, and most importantly in causes that are related to social circumstances such as suicides or alcohol-related deaths. But these are the economic fluctuations, but also our current crisis sometimes is called the Great Recession, which bears resemblance with the Great Depression in the United States in 1930s. And this is the study that looks exactly at the Great Depression, where the trends in all-cause mortality were going down during the Great Depression, but looking at the data at state level, looking at the death certificates, what the authors found here is that suicides were going up and road traffic accidents were going down, and that was related to bank suspensions in specific areas, whereas all other mortality changes were unrelated to the changes in the economy and were more related to overall epidemiological transition. And another crisis that is more recent and is probably is much more familiar here is the collapse of the Soviet Union in the 1990s, which resulted in tremendous loss of life and 5 to 7 years loss of life expectancy in males, 2 to 3 years loss of life expectancy in females. And here on the graph you see the mortality rates in Russia and in Belarus, and these two countries have implemented changes quite differently. Russia implemented shock therapy, decided to privatize state assets very quickly, whereas Belarus opted for more gradual change. And their mortality patterns are quite different. So changes in death rates were associated with privatization pace, but also what the authors found here is that the level of social cohesion could mitigate the impact of the crisis on mortality. So for example, in countries where larger proportions of population were members of social clubs or sport clubs or religious communities, something that Professor Punjus was just talking before that, it did protect, it mitigated the impact of the crisis. In these countries, mortality pattern was different. And now we know a lot about what happened during that period of time, but do we know what's happening with the crisis right now? And this is, I'm sorry, this is a little bit small, but this is actually the screenshot from the Health for All database as of the latest update in July 2013. And it shows the mortality data that we have, some from 2011, some from 2010, and there are countries from 2009. And this is the mortality data that we have to operate with. And this is the screenshot from my phone from today. And this is the data that I don't even ask for. It's a FTSE 100. I get it by a minute with no delay completely. So we don't have any recent timely data on health. We have to operate with about 2 years lag on mortality data, and the data on morbidity has very serious comparability issues. But some things we do know, and this is the changes in suicides that happened since the crisis, and this graph is indexed to 2007. And until then, the suicides in European Union, both in new members of European Union and old member states, suicides were going down, whereas after the crisis, the rate started going up and leveled a little bit by 2010. And although we don't know exactly for every country, but for some countries we know that these are changes in historical trends, and they are significant. For example, this is the study from England that looked at changes in suicides, and the authors found about 1,000 of excess deaths related to the crisis between 2008 and 2010, and that was related to increase in unemployment. And this is another study done by Dr. Reeves here, and who found that there were about 5,000 excess deaths between 2008 and 2010 in the United States, also related to unemployment. And same picture comes from Italy. This is excess suicides and attempted suicides. And in Italy, that triggered the first grassroots movement for protecting mental health that was done by widows of men who committed suicides due to the deterioration in economic conditions. Similar picture from Spain, although we don't see it exactly in the trends, there is a step change in suicides after the beginning of the crisis. And this is the data from Greece, and for 2 years the Greek government didn't want to admit that, but the data has been made public in the summer now. And there is a 45% increase in suicides between 2007 and 2011. And actually in the females, the number is much smaller, but the increase in working age females is almost double as it was before. But suicides is just the tip of the iceberg. It's a sign that generally mental health has deteriorated, and studies in England have been done using 2 different data sources, and they both show deterioration in mental health. It's just one related to employment and the other one doesn't. Also, similar case in Spain. There was an increase in major depression, anxiety, and other disorders, and most importantly, increase in major depression was related to circumstances such as unemployment or mortgage repayment difficulties or evictions. And for Greece, again, there was an increase in major depression and increase in suicidal ideation and attempted suicide, and there was a major increase in the use of mental health service over 3 years. So what has the government of Greece done in response to that? Well, they cut mental health funding by 20% first in 2011, and then they just halved it further in 2012. And it's not just mental health that suffered in Greece. As the result of austerity measures, we see now a rise in infectious diseases. So Greece is right now at the epicenter of infectious disease epidemics, including malaria. And yes, the vector needs to be present, and yes, it needs to be certain climatic conditions, but the austerity had an impact on mosquito spraying programs, and that resulted in a resurgence in malaria for the first time in 40 years in Greece. And it's not just malaria, there was an increase in new cases of HIV among the injecting drug users, and from 10 to 14 cases annually between 2008 and 2010. It increased to over 200 in 2011, and then it further increased to over 500 in 2012, and that was also linked not just to deteriorating socioeconomic conditions in Athens city center, but also to cuts in prevention programs. And here is the data from across Europe in access to care, which is reflected in unmet medical need. This is the data from European Union survey on income and living conditions. And there on your right-hand side, this is just example from Latvia, where where unmet medical need increased from about 10% to about 16%. So that goes back to what Monika Kozinska said today in the morning, that shouldn't we raise the concern when countries see big increase in unmet medical need. And Lithuania is also here on the graph, but it's actually done quite well during that time, but it doesn't mean that there aren't any groups within groups and vulnerable people that are affected by the impact of the crisis. And we've looked in more detail on unmet health need in Greece, and we compared 2007 to 2009, and we saw a rise of 15% first. And we've repeated this exercise again in 2011, and the increase in medical need was 47%. And the main reasons for that were cost, waiting lists, and distance. So it's attributable to cost shifting to patients, and also to austerity measures or overburdened health services. And is there any alternatives to what Greece has been doing? Well, there is another country in Europe that also had a crisis quite early on, and this is Iceland. And the crisis was quite deep, and Iceland has quite good data. And from what we saw, there were no specific health effects as a result of that. For a bit, Iceland considered to implement austerity measures by the IMF, but then they put it to referendum, and 93% of population said no, they didn't want that. And the surveys show that there was some improvement in lifestyle. There was reduction in tobacco use, reduction in alcohol consumption. There were mixed effects on diet, reduction in consumption of fruit and vegetable, and increase in consumption of fish oil. And there was an increase in hours of recommended sleep. And also across Europe, we see a little bit more of good news. So this is reduction in road traffic deaths, and also some improvements in lifestyle, smoking and alcohol consumption, probably working through price mechanisms. But at the same time, when studies look into more details, we see increase in binge drinking among people who tend to drink more, and also we see increase in smoking among the unemployed. So just to wrap up, I would like to say that the effects of crisis on health are already visible, and crisis had an impact on health, and particularly on mental health, and there probably are a lot of effects that we just don't know about. Social safety nets, formal and informal, can protect health and can mitigate the impact of the crisis. Austerity measures implemented in health sectors, such as cost cutting or increase in user charges, can exacerbate the impact by reducing access to care and quality of care. And differing policy responses to similar set of shocks created by the crisis have different health outcomes, and this would be a great potential for future research of the policies that were implemented in the countries, and also why some societies do better in the crisis than others. And just to mention, as Observatory is tracking the impact of the crisis on health, and these are the resources that you can use to monitor it with us. Thank you very much.
Thank you, Marina, and we have to thank all the WHO team of European Observatory for such wonderful data and such good evidence on crisis management and the impacts.